Hello and welcome to the online course, Communication Frameworks for Clinical Utility. This is video 2, more about clinical validity. It's the second of 4 videos. The first one is 20 minutes long and provides a general framework. This one focuses on clinical validity, the next video on clinical utility, and a final fourth video uses the framework to work through some specific examples. Let me give a brief recap. Too often when we have a new molecular diagnostic test, or perhaps a different kind of diagnostic test like a PET scan, the payers say your test lacks clinical utility, so you need more clinical utility. You don't really know what to do next. If we're playing the right game, we'd say, I understand the value proposition of your test. 30% of surgeries could be safely avoided, but I'm not convinced it will happen. I'm uncertain because of A, B, and C. And to move forward, we should talk about addressing A, B, and C. The executive summary is that just talking about analytical validity, clinical utility, it's just 3 noun phrases or 3 nouns. It doesn't tell you what to do next. And the framework here will talk primarily about categories of diagnostic tests from a clinical validity standpoint. This is our main diagram that all diagnostic tests that are new will have some gain in clinical validity compared to what we had before. That'll have some impact on management and therapy, which will cause a gain in clinical validity. And we have 6 questions we matched to this diagram. First, who should be tested and under what circumstances? 2, what does a test tell us that we did not know before? 3, can we act on the information provided by the test if everything was ideal? 4, what really happens in the real world? 5, does the outcome change in a way we find value in? And 6, can we afford it? And note that questions 2, 5, and 6 are comparative, so you will need to say against what comparators, in what units, and with what uncertainty. So a way that we approach really hard problems is often to use categories. This is a great book called 10 Types of Innovation by Larry Keeley, and he says that if you look at all different kinds of products in the real world or on the internet or on your smartphone, there are 10 basic kinds of innovation. It could be more features, simpler to use, cheaper, delivered faster, more variety, more customer service, and so on. So we asked, are there a finite number of ways to improve clinical validity? And in this course, we argue that there are 7 that we'll talk about. The first is doing exactly the same thing. The third is better sensitivity, better specificity, or better accuracy. The third is measure a target that's entirely new. We'll see that introduces some new features. 4, more accurate prognosis. That introduces some very interesting things. You can reflex to resolve an ambiguous test. Pathologists and laboratorians have been doing that for 100 years, and we'll see what that leads to. We can provide a diagnosis where all other methods failed. But that raises the problem there's no gold standard, so what happens then? And finally, we may rule out patients for something. So we have a diagnostic test that actually rules out some other diagnostic test that we don't need to do. So we'll walk across these categories. To do exactly the same thing, let's say we have a test to measure HER2/neu, and now we have something that's cheaper. Or maybe it's an analyte-specific reagent that costs 1/3 as much as the FDA-approved kit. So if you're doing exactly the same thing, you have to establish that, and hopefully you're not doing it more expensively. So we'll probably ask, are you doing it faster or cheaper? The second category is better accuracy. So let's say the old test was 90% accurate and the new test is 95% accurate. So you need to define that in a rigorous way, the old test versus the new, and there may be more than one old option. And then people will say, well, okay, with that 5% difference in accuracy, what really happens to patients? But you start with the better accuracy. Another example is that you can measure a test that's entirely new. So when we were introducing tamoxifen as treatment after breast cancer, the first estrogen receptor tests were entirely new. We had never done anything like that before clinically. When we were looking at Erbitux and other drugs for colon and lung cancer, we started testing EGFR. Never had done that before. Circulating tumor cell tests, a very interesting modern category of tests, and it measures something, circulating tumor cells, that you just couldn't measure clinically before. So it's something that's entirely new. Another category is more accurate prognosis. The best known modern example is the Oncotype DX test, which is a 21 gene test run on breast cancer samples, and they provide a more accurate prognosis than other things like tumor size or tumor grade. However, it turns out it's very hard to quantify this in a way people easily grasp. So you can have a higher R value, or you can have a smaller P value, but people will just sort of stare at that. They won't know what that means. You can have a reclassification index. That's more actionable, although if you get into the literature on that, there are pros and cons or ins and outs of reclassification indexes. And then finally, that delta, that bigger R value or the reclassification index, how does that really have clinical impact? Another example is you resolve an ambiguous prior test. In the first video, we talked a little bit about the Veracyte-Afirma test. People have an indefinite fine needle biopsy of their thyroid nodule, and then you roll out this much more expensive but more accurate test to help resolve that. And if you resolve it, you're doing what you were trying to do before, which is decide if they have thyroid cancer or not. So we know what to do with the result. Another example is providing a diagnosis where all other methods have failed. That means that there's no gold standard. In the last 5 years, several companies have brought forth cancer of unknown primary of tumor or tumor of unknown origin tests. But the problem is there is no gold standard, so that independent parties, technology assessors, or payers will say, was it really the same thing? Is this really colon cancer? Because your gene panel test says that, but we have no gold standard to compare against. And so the technology assessments can bog down. Finally, we may rule out patients for something. The Lilly Amyvid test, a PET scan used for Alzheimer's disease, will rule out the patient cannot have Alzheimer's disease. The XDX AlloMap test is a molecular test used in heart transplant patients, and it can rule out in most months that they don't need a cardiac biopsy to look for rejection. The Cardiac DX Chorus CAD test is now covered by Medicare. It's a test to rule out patients that may not need more invasive or more costly cardiac imaging or treadmill tests. Let's look at the Oncotype DX test now as a case study. So the main value principle is that it has a more accurate prognosis, shown here in the middle. But if the viewer does not accept that it's really more accurate or meaningfully more accurate than glass slides, tumor size, tumor grade, then you'd say the prognosis is only doing the same thing that we already had before, but at much higher cost. On the other hand, if you accept that it's a more accurate prognosis, it helps you rule out some women that don't need breast cancer chemotherapy, adjuvant chemotherapy. And now, if you're going to rule them out for not having chemotherapy when we would have given chemotherapy before, the bar is going to be very high. People are going to want to be very sure that the test is accurate and safe. And so they're going to want every one of those 6 questions answered twice or answered very rigorously. Let's look at the cancer of unknown primary tests. Now we said these will take a cancer of unknown primary and provide a diagnosis 80 or 90% of the time when all other methods have failed, like flow cytometry, imaging, and immunohistochemistry. But the reasons these seem to be very controversial, at least based on a Medicare public meeting in May of 2013, the opponents said, there is no gold standard, so we have no idea what you're doing. The proponents said, we're doing exactly the same thing we were trying to do before, but in cases when we couldn't accomplish it. But now we're doing it faster, better, and more accurately. So if the parties are arguing way over on the left versus way over on the right in terms of the value proposition, unless they recognize that, they're just going to yell at each other and not make any progress. One thing that makes this a little more useful is that I think the different test classes naturally will lead forward into different kinds of clinical utility outcomes. So you'd be asking different clinical utility metrics. If you do exactly the same thing, hopefully you do the same thing but cheaper. If it's more accurate, that's easiest if it's a similar price or a proportionate price. If you measure the targets that are entirely new, often combination of diagnostics have fallen here. If you have a more accurate prognosis, we want to know exactly how the management pathway changes and by how much. Are there any risks of the new test? For the reflex flex to solve an ambiguous test, the questions are probably the same as if the prior test had worked. So we're actually in a better starting point there. They tend to go fairly well. We've talked about diagnoses where all the other methods failed. And then if you rule out patients for something, the payer will want to know really, how often, is it safe to do that? So you want to have metrics that address these questions. And if you don't address these questions, you probably will bog down. That's the end of the second video. If you enjoyed this, the third video will be about categories for discussing clinical outcomes. Thank you.